All right, guys, welcome back to Underground Science. In this video, we'll be talking about hemophilia A, okay? So now we're talking about diseases affecting your coagulation factors rather than platelets, all right? So a little background, remember our coagulation cascade, right? Our extrinsic pathway starts with factor 3, which then helps activate factor 7, and then factor 7 this whole pathway, the extrinsic pathway eventually converges to factor 10, right? And then if we look at the intrinsic pathway, it's a little longer. So we start with factor 12, then we get factor 11. That's an H, not an 11. Then we get activation factor 9, right? And then we have our cofactor, which is factor 8. These two together can then converge onto factor 10 also. All right. So this is the intrinsic pathway, and this is the extrinsic pathway, right? And then, of course, we know the common pathway is factor 10, eventually activates factor 5. Factor 5 eventually activates thrombin or factor 2. Then thrombin can help convert fibrinogen into fibrin, and fibrin can help form a stable platelet plug by cross-linking the weak platelet plug, right? So, and this can cross-link and form stable, a stable clot, basically, right? Stable platelet plug. So you need fibrin, right? And the only way you're going to get that is through the intrinsic, extrinsic, and common pathway. Now remember, thrombin also stimulates platelets and stimulates platelet aggregation, right? Remember that. And then we should also remember that thrombin can also help activate factor 13, all right? And it's actually factor 13, right? We should be more specific. It's actually factor 13 that will stimulate the cross-linking of fibrin. Okay, so we need factor 13 too. All right, so that's the quick basic rundown of the coagulation cascade. Now in hemophilia A, okay, it's an X-linked disorder. It's X-linked recessive actually, okay? And in hemophilia A, what happens is you're deficient in factor 8, okay? So you're deficient in factor 8. So right away, if you're deficient in factor 8, then that means that you can't really the intrinsic pathway can't occur. And if the intrinsic pathway can't occur, then you can't make fibrin. So you can't properly cross-link your platelet plug, and you can't have a stable clot or a stable platelet plug, right? So you're going to get bleeding. Okay. All right. So you're deficient in factor 8 in hemophilia A, right? And what pathway is this affecting? The intrinsic pathway. How do we monitor the intrinsic pathway? Through measuring the PTT, right? How do we monitor the extrinsic pathway? By measuring the PT, right? So if factor 8 is deficient, then we can expect the PTT to be elevated. However, nothing's wrong with the extrinsic pathway, so PT, right, we can expect to be normal. Okay, so I hope that makes sense. Now, if we have a deficiency in coagulation factors, remember when there was something wrong with the platelets, either something wrong with the glycoprotein 1B or 2B3A, or we had thrombocytopenia due to ITP or TTP or HUS, right? We saw skin and mucosal bleeding. But if you have deficiencies, right, or defects in your coagulation factors, you see more deep bleeding, not skin and mucosal bleeding. Okay, so you'd see deep bleeding instead of mucosal bleeding. Like what? Like hemarthrosis, right? What's hemarthrosis? That's bleeding into your joints. So that can lead to swelling and painful joints, limited range of motion, right? You can see things like muscle hematomas. What's that? That's bleeding into your muscles. For example, you can bleed into your quadriceps muscles. You can bleed into your calf muscles. You can bleed into your hip flexor muscles like your iliopsoas muscles, right? Which is basically a combination of your iliacus and psoas major muscle, right? So you can bleed into your quads, for example, right? You can bleed into your iliopsoas muscle, for example. You can bleed into your calf muscle, for example, right? So let's write that down. It's actually fix the spelling of this. This is iliacus, just with one L, right? So both of these, you can see that makes it the what? The iliopsoas muscle, right? Which is a major hip flexor muscle, as we know from anatomy. If you bleed into this, this could lead to compression of your femoral nerve, okay? This could lead to compression of your femoral nerve, which can, of course, lead to things like numbness and tingling and whatnot. So things like that can happen. And if you do bleed into your muscles, like your calf muscle, for example, you can get pain, swelling, things that mimic a DVT, okay? So you may see symptoms that mimic a DVT, deep vein thrombosis, all right? So that's important to note too. So it's basically more bleeding into deeper structures when you compare it to platelet disorders, right? You can even see things like bleeding, right, after surgery, right, is a common thing you can see with defects or deficiencies in coagulation factors, right, or bleeding after trauma. And something horrible, right, would be, but something you can see is CNS bleeding, right? So if you get a minor head injury, that could be deadly because you can bleed a lot, especially if you're deficient in your coagulation factors, like in hemophilia A. By the way, hemophilia A is the most common type of hemophilia, so we can write that up top, right? Most common type. Okay. So we don't really see mucosal bleeding, right? Because that's what we see mostly in platelet disorders, but this is not a platelet issue. All right. So So let's move on, right? I think we just talked about most of it in that first slide. So if we just do a quick review, it's X-linked recessive. Factor VIII deficiency is seen in hemophilia A. So then you can't form a proper fibrin clot, defective secondary hemostasis, right? Because coagulation factors and the formation of fibrin is secondary hemostasis. Okay, so we already talked about this. We'll see hemarthrosis, bleeding into joints, which can lead to painful joints, limited range of motion, swelling, and whatnot. Muscle hematomas, bleeding into muscles like your quads, your iliopsoas muscle, your calf muscle, can lead to symptoms mimicking DVT, right? And we also said prolonged bleeding after trauma or surgery. And we also said we can see CNS bleeding after minor head injury too, which can be deadly. All right, so those are the main clinical features. Now, lab findings. Remember, the problem is factor VIII here. Factor VIII is part of your intrinsic pathway. We measured the intrinsic pathway via the PTT test. So we can expect the PTT to be elevated. Is anything wrong with factor 3 and 7? No, so the PT is normal. Is anything wrong with the platelets? No, so the platelet count and bleeding time is normal. Okay, but you have low factor VIII levels. Okay, and why did I mention normal von Willebrand factor levels? Because von Willebrand factor stabilizes factor VIII. Okay, so if you had low von Willebrand factors, then you could see bleeding symptoms relating to bleeding symptoms similar to as you would see in a deficiency in factor VIII, because von Willebrand factor stabilizes factor VIII. Okay, but obviously you wouldn't see, like, if you had von Willebrand, if you had low von Willebrand factor, right? You may see mild bleeding symptoms that mimic factor VIII deficiencies, right? But it won't be as severe as hemophilia A, of course. All right. Now, before we move on to the treatment, one thing I want to mention is because your PTT is elevated, right? What you would want to do is a mixing study, okay? Because you want to know, okay, is this due to a coagulation factor deficiency, or is this due to some sort of antibody or coagulation factor inhibitor, right? That we have. So if you do a mixing study and you mix normal plasma into the plasma of a patient with hemophilia A, then that normal plasma will contain normal amounts and functional um, factor VIII, right? So you're giving functional factor VIII from the normal plasma. Okay, so this is you're going to have functional factor VIII from the normal plasma. And if you mix this with plasma belonging to a patient with hemophilia A, right? Then now that plasma that belongs to the patient of hemophilia A will have normal plasma, which contains normal factor VIII. So then the PTT, after you do this mixing study, we would expect it to correct, right? So the PTT would then correct and be normal because you're giving the plasma belonging to the hemophilia A patient, you're giving that plasma normal amounts of factor VIII and functional factor VIII. So your PTT would correct. But what if you had a factor inhibitor, right? We'll actually discuss this in a separate video, but if you had a factor inhibitor, okay, and that was causing low factor VIII levels. So if you had, for example, a factor inhibitor against factor VIII, right? And then if you mixed normal plasma, so you gave functional factor VIII, you gave more functional factor VIII to this patient's plasma who has a factor inhibitor against factor VIII, the PTT wouldn't correct because then the antibodies in this patient's plasma who had the factor inhibitor would then just bind the extra factor VIII given, right, by the normal patient's plasma. So your PTT still wouldn't correct. So that's how you can differentiate between whether or not the patient actually has a coagulation factor deficiency or whether the patient has a factor inhibitor, right? So that's important to distinguish. But that's basically it, right? If you do the mixing study, in fact, and the PTT corrects, that indicates a factor deficiency. Okay, so that's hemophilia A. Okay, something else that we could mention that just came to mind is in terms of the treatment. If you have minor hemophilia A, right, then you have a minor deficiency in factor VIII, right? So if you would give this patient desmopressin, because remember what desmopressin does is it increases von Willebrand factor, right? And von Willebrand factor, we said, stabilizes factor VIII. Okay, stabilizes factor VIII. Remember, the problem was the mild deficiency in factor VIII. Okay, only if this patient has mild hemophilia A, so a mild deficiency, then giving desmopressin can increase von Willebrand factor and stabilize whatever factor VIII they do have, therefore helping reduce the PTT a little bit, right? But if you have moderate to severe hemophilia A, the main treatment would be recombinant factor VIII. Okay, so that's basically what I wanted to discuss in this video for hemophilia A. All right, so hopefully this video wasn't too confusing. Hopefully it made a little bit of sense. Thank you guys for watching. See you guys in my future videos.